Hey everybody. I talk a lot about ventilation and I focus a lot on the physiology or how a ventilator delivers a breath. But from a practical perspective, sometimes that leaves out some of the basic things we need to do at the bedside, like offer initial ventilator settings. So today's lecture is going to focus a lot on setting the ventilator at the start and then adjusting the ventilator and how we think through adjusting the ventilator. I hope it's useful for you. Now, our goals of mechanical ventilation are, of course, to ventilate, which means to clear CO2. We also want to oxygenate adequately. But importantly, while we're ventilating, we want to do that safely. And of course, we want to do that in a way that the patient tolerates and is reasonably comfortable during the ventilation. And this is important because if we screw up our ventilation, the patients are unable to really succeed at a spontaneous awakening trial and spontaneous breathing trial. And so if you ventilate people well and comfortably, you can improve their outcomes with regards to their brain. You can decrease their risk of PTSD, and you can decrease the cognitive loss that happens in critical illness by picking ventilation strategies that are comfortable for the patient and let them get less sedation. If we focus on those goals, the first target is to ventilate or clear CO2. There's a lot of physiology building into this, and I'm just going to dance over the topic since the focus of this is mechanical ventilation, not respiratory physiology. But we know that we ventilate off CO2. The more you breathe, either with the speed of your breathing or with bigger breaths, the more CO2 you clear. Minute ventilation is shorthanded always as VE, or exhaled minute ventilation with a dot over the V, and it equals the respiratory rate times your tidal volume. It's a simple math equation. It's nifty because if you can do this at the bedside, you can make rough guesses as to what changes in these things will do to your CO2. And to understand that, we just know that the change in your minute ventilation has a direct association to the opposite change in your CO2. Let's use that from a practical perspective. If you're on standard vent units of a respiratory rate of 10 with a 500 milliliter tidal volume, and your CO2 is 44, if you want the CO2 to go down 4 and normalize to 40, that's a 10% reduction in CO2. So you're going to want to go up on your minute ventilation by 10%. With a respiratory rate of 10, going up 10% is easy. You turn the respiratory rate up 1. In most typical ranges of patients and minute ventilation, this works out. Not always in patients with lots of dead space who are sick or at extremes of ventilation limits, but most of the time this gives you a pretty good eyeball for changing the ventilation towards a CO2 goal. Now, of course, it's a little bit harder than this. The tidal volume itself includes the part of the lung that does the actual gas exchange, the alveolus, but it also includes a lot of air going in and out of the body that really does not participate in gas exchange, and we call that dead space. It's everything like the trachea, the mouth, all the smaller airways and big airways in the lung, everything between the actual alveolus and whatever is being measured in your tidal volume. That's called dead space. And dead space has two components. One is anatomic, right, all this stuff. And then there's also some physiologic dead space of alveoli that are open but not getting great blood flow. And that, again, delves into respiratory physiology, but it's some amount that can differ on the patient in front of you. The anatomic portions are fairly fixed, and that becomes a key concept in a little bit. The very important thing to remember as you get patients that are sicker with lung disease is that what actually does CO2 exchange, so how you actually breathe out CO2, is alveolar minute ventilation. And alveolar minute ventilation is the respiratory rate times the tidal volume minus that dead space, or your alveolar ventilation, the tidal volume that actually gets to the alveolus and does its work there. The reason this is relevant is that we use fairly small tidal volumes in modern practice. So if you have a fairly fixed dead space of, say, about 150 milliliters typically, as your tidal volume goes down, the alveolar component is what is decreasing. And so as you go down in the tidal volume, because the patient has ARDS and non-compliant lungs, you decrease the alveolar minute ventilation more than your dead space. And that fraction means that for each breath, less and less of that breath is actually doing gas exchange. So if you compare a 500 mil tidal volume to a 250 mil tidal volume, you didn't lose half of your ventilation of CO2. You lost much more than half of your ventilation of CO2 because the actual alveolar portion of that goes down, down, down. So as tidal volume goes down, your minute ventilation goes down even more. This is a very key concept when we're adjusting the ventilation for a sick patient. As a framework for adjusting the ventilation, it's always good to have a starting point to work from. I always call these standard international ventilator units. In pressure ventilation, we normally start with a rate of 10 to 15 and a pressure of 10 to 15 in a healthy person over a PEEP of 5 to 10. Now, starting PEEP is a discussion for another talk. We generally underutilize PEEP for most of our patient population in the United States who are a little bit more obese and lying flat where their belly is collapsing those lower airways. We start at a normal FiO2 of 40%, and generically, IDE is always talked about as 1 to 2, which gives you normally an inspiratory time of 1.5 to 2 seconds based on your respiratory rate. And if you're setting the I time, we normally pick a shorter I time to start of about 1 second. I don't know why that happens anecdotally or clinically frequently, but as you look at the ventilator, you should be adjusting that as you go. Volume ventilation has standard vent units too. The rate, PEEP, FiO2, and IDE are not going to be very different. But instead of setting the pressure, we set the tidal volume. I prefer volume control with decelerating flow if you can. It tends to be more comfortable for the patients, and generically we start at around 500 milliliter tidal volume. So once you pick the initial ventilator settings, the first thing you want to do is make sure that they're safe and reasonable for the patient in front of you. If they're very short and very tiny overall, you don't want to pick 500 milliliters. And if they have very dangerously non-compliant lungs like ARDS, you similarly don't want to be giving big tidal volumes or high pressures. So the starting point is to find the perfect breath. And by perfect breath, I mean that you've found a breath that is safe for the patient and is as close to physiologic as you can get. So if you pick a tidal volume of 500 and the pressure it takes to get that tidal volume is 25, you got to turn that tidal volume down. So you want to adjust it to make sure it's safe. If you start with an inspiratory pressure of 10 and the tidal volume is only 200 milliliters, you're going to need to go up on that inspiratory pressure to a safe number like 14 or 15 in a way that helps you. So again, finding the ideal breath normally means that you have the most volume that's safe for the least amount of pressure, and you set that. The safest tidal volume or pressure, of course, that you're delivering is enough for your goal minute ventilation or CO2. So if you need to be ventilating somebody rapidly, you're trying to, say, counter some acidosis or fix some respiratory acidosis quickly. So you don't want to pick a tiny tidal volume then. And you want to make sure the patient can handle it. If you put your patients on a tidal volume of 100 milliliters because small tidal volumes are better, they're not going to be comfortable, they're not going to wake up, and this is bad. Now, we keep revisiting this ideal breath, and it's the top part of our ventilator adjustment curve. And from this, we always are going to work through the rest of the situation here and revisit ideal breath. So let's walk through that a little bit more. The first thing that we look at when we're setting that initial breath is to make sure the inspiratory time is appropriate. And if you've watched my prior videos on pressure control and volume control, you know that when I'm in pressure control, I try to aim for an inspiratory time that cuts the decelerating flow pattern off around 1/4 or so of the peak. Lots of great clinicians try to use the entire inspiratory time up or even have an inspiratory pause, which can be useful. But as a starting point, I aim for that about 1/4 of the peak. And the reason I use a shorter inspiratory time than others occasionally is because I like to make sure my patients don't air trap. And if you've gone through my past videos, you've seen pictures and different instances of air trapping. Since the ventilator doesn't exhale for people actively, we need to make sure that we set safe inspiratory settings so they have enough time to passively breathe out for you. So I make sure the patient fully breathes out. And then from there, I like to make sure I didn't set the inspiratory time too short. So again, in a pressure type of breath, if I have really short inspiratory time, I'll get tiny tidal volumes. And if I have a way too long inspiratory time, I might be cutting off some of my expiratory time. So again, generically, a good I to E time is around a second or so. And often when we're in smaller tidal volume situations, we use a little bit shorter than that, 0.9, 0.85 seconds. And that roughly lands to a 1:2 to 1:3 inspiratory to expiratory ratio. Once we know that our I to E times are appropriate, we want to look somehow at their blood gas or at their minute ventilation and target something, right? You don't want to have a patient fully sedate and riding the ventilator when you are not ventilating enough. You can do that with an end-tidal CO2 where you have a rough idea of what their CO2 is. You can do that with blood gases. Or you can do that by rough guessing their minute ventilation in an average situation and making sure it's in a normal range of somewhere in that 6 to 8 or 10, in that minute ventilation range if you're short-term ventilating someone. I like to use end-tidal CO2, of course, in the operating room and either end-tidal or blood gases intermittently in the ICU environment. I check what they are and I decide what's acceptable. What's acceptable is a very patient-specific situation, but if you have a really sick patient, it's quite normal and typical to use a higher CO2 goal. In other words, to ventilate them less in order to not overventilate them and hurt them with the ventilator and cause ventilator-induced lung injury. Now, since I know I set a safe, ideal breath where I have the most volume for the least pressure, when my blood gas is off, I predominantly use a respiratory rate to target the CO2 and minute ventilation that I want. I don't adjust the breath. So your first move is to set a safe breath, and when you need to adjust it, you adjust using the respiratory rate. If you need to adjust the breath, that's okay, but you need to make sure it's still safe. Make sure you revisit your inspiratory and expiratory time. Now, I've briefly hit on this in other lectures, but it's important to remember what safe ventilation means. We know that pressure, or the pressure a vent is delivering above the PEEP, the driving pressure, is probably the most critical driver of ventilator-induced lung injury. More than volume trauma, more than atelectotrauma, although both of those things are bad too, and always try to not hurt your patients in any way. When I think through delivering the least amount of pressure, you have to recall that in pressure control, what you set is the injurious thing. So you set the inspiratory pressure, which is your driving pressure, over the PEEP. In volume control, you have to look a little bit more because what you're looking for, the driving pressure, is a variable based on the patient in front of you. So it's not what you set, it's what you get. And it's that plateau pressure minus the PEEP. Remember, in volume control ventilation, you often get the peak and a plateau. The peak pressure really doesn't hurt the alveolus, but the plateau pressure can when it equilibrates. Go watch those videos if you need a short reminder. Our magic number we look for when we look at the high pressure minus the or the PEEP, is 16. And so when we look at the ventilator itself, Here's our pressure control. We want to have the P high less than 16 above the PEEP. Here we have 10 over 6. So a PIP, a positive inspiratory pressure of 16, but a driving pressure of 10. The 10 matters much more than the 16. As the ventilator is showing that you might have a high driving pressure based on the mode you've picked, in other words, your driving pressure is higher than 16, what do? Well, of course, we try to fix things that you can. You're going to sit the patient upright so their abdominal weight is not pushing on the diaphragm. You're going to do your best to optimize the PEEP so that their lungs are as compliant as they get. You may decide to prone a patient that has ARDS. Once you've done all those things, diuresed the patient, antibiotics, and more, you're stuck with needing to adjust the ventilator to make the ventilator safe. And once you do that, you simply have to adjust your pressure or volume until your driving pressure is 16 or less. As you do that, the CO2 will go up, right? So as I set a safer breath, that ideal breath, I make sure my I/E times are okay, and then the CO2 is going to go up because I'm ventilating less. Smaller tidal volumes, higher CO2, less ventilation. So what do? I adjust the respiratory rate. From there, I revisit everything. I make sure that at a faster respiratory rate to breathe off the CO2 that's going up, that my breath is safe, and that I still have enough time to breathe out, because now I'm using up a lot more time breathing in because of that higher respiratory rate. Once I know that's safe, I re-look at my blood gas or my CO2 in another way. And if it's still high CO2, and if the ventilator is still too much injury, I have to go down on the volume and revisit all of this. And the CO2 may keep rising. I keep getting safer, and eventually you'll have a respiratory acidosis that prompts you to go down a VV ECMO pathway. And this is a common path towards ECMO in an ARDS patient. I've really focused a lot on safe ventilation for driving pressure, and that's the key thing to hurting someone on a ventilator, is how much pressure you deliver above PEEP, how much energy or how much you have to hit the lung to get the volume you want. But of course, volume trauma matters. Avoid very large tidal volumes. And atelectotrauma matters. If you are not using PEEP and they have a bunch of atelectasis in between each breath where the small alveoli close and collapse, and then you breathe for them and you open up all those small alveoli, this is bad for you. The way you prevent atelectotrauma is by providing the optimal PEEP. We remember that when we blow up a balloon, when you start blowing it up, it's not compliant. So we know that alveoli that are collapsed when you have atelectasis, for example, we know that worsens your compliance. So if you've picked the right PEEP for your patient, you should have minimal atelectasis or small collapsed alveoli. You can check out my video on optimal PEEP to do a review on how we set an optimal PEEP. All right, so what do we do to set a ventilator? First, you pick a starting point and adjust it for that safe, perfect breath. You want the most volume that can be comfortable, but is also safe and not a high amount of pressure to get that breath. We always look at our inspiratory and expiratory times because we remember that really short inspiratory times yield a bunch of pressure to get the same volume, and really long inspiratory times give us no time to passively exhale. Once we know we have a good inspiratory time and we are not air trapping on the expiratory side, we assess our minute ventilation by assessing our CO2. How well are our ventilator settings actually clearing the CO2? Do we need to breathe more or do we need to breathe less? Since we know we picked a good breath to start with, when I know I need to adjust the CO2, I do that mostly by adjusting the respiratory rate. Once you adjust the respiratory rate, you start over. You re-look at your breath. Is it safe? Are the times appropriate? And from there, you just circle around again and make sure that the ventilation modes you're setting or settings that you've picked are clearing enough CO2. Now, I really focus a lot on ventilation and not oxygenation, and of course a ventilator oxygenates. The simplest thing on a ventilator to help you oxygenate is to go up on your FiO2. What we often see is that people then go up on PEEP. And it's very important to remember that while PEEP is associated with hypoxia, right, less PEEP or not enough PEEP is associated with more hypoxia, there's something that really modulates that relationship. And that's things like atelectasis, poor compliance, de-recruitment. And those things really drive your hypoxia, and those things are associated with low PEEP. Not all hypoxic patients, however, actually need more PEEP. We saw this in COVID all the time, where COVID patients, when they presented, were terribly hypoxic, but their PEEP requirement to target their good compliance and open lungs was actually very low. Then they either got better or progressed, and as they progressed and the lungs became more injured, leaky, or fibrotic, their PEEP need went up over time. So both patients were hypoxic, but only one half of them had a need for higher PEEP. So there's a modifier to the hypoxia and PEEP relationship, and you shouldn't simply pick a PEEP based on a severity of hypoxia or by an FiO2. Your PEEP should target the optimal compliance for your patient. There's always a range of optimal PEEP, and you got to consider that when you're thinking about oxygenation targets and when you're thinking about other things that high PEEP can impact, like the right ventricle. Check out my lecture on optimal PEEP. It's worth looking at. But remember, when we're oxygenating, it's not just FiO2 and PEEP. You got to do a little more than that. And there's, of course, rescue things like nitric oxide or epoprostenol. Now, comfortable ventilation is key to our ventilator settings, and you should definitely check out all the other videos I have on ventilator synchrony. If you've seen those, give yourself a quiz by looking at these here. But when we don't pick the right ventilator settings, patients are unable to get sedation holidays. They get more drugs, more medicines, they're agitated, and all those things will drive terrible long-term ICU outcomes like PTSD or even cognitive loss. These are big deals, and they happen frequently, and we can prevent them from happening in some patients by picking good mechanical ventilation settings. So again, how we ventilate people, our main aim is to pick a really good, safe breath. We look at the inspiratory and expiratory times to make sure they're breathing out all the way and they have an adequately long inspiratory time. We then figure out if that minute ventilation, what we've set on the ventilator, is enough for that patient. And from that, we adjust the respiratory rate. Once we get that respiratory rate keyed in, we go back and look at the ideal breath for the patient. That might mean that it looks like the patient has a small tidal volume for the energy or the pressure we're delivering. So we'll want to adjust the PEEP, optimize compliance. And from there, we'll relook at what the ideal breath is by trying to get the most volume for the least pressure. Again, most volume for least pressure means we get the weight of their abdomen off of them. We might turn them prone. We diurese them if they have pulmonary edema or give antibiotics for pneumonia. Once we've done all of those things, we look at the ventilator and make sure we have an optimal PEEP setting that gets us the most compliant lung. We set a safe breath and restart. Look at your inspiratory and expiratory times. Is that minute ventilation enough for the patient in front of you? Target adjustments by mostly adjusting your respiratory rate. The goals of ventilation, mechanical ventilation is of course breathing off CO2, adding oxygen, but critically we want to do this safely and we want to do it comfortably. We can do a lot of ventilation and a lot of oxygenation in ways that hurt people, We don't want to do that, so never forget those final goals. I hope this served as a good outline and framework for how you start picking an actual ventilator mode and how we move through the process of adjusting ventilation. Happy ventilating, everybody.